Greetings and a warm welcome to everyone. This is Rupsha, the assigned moderator from ClearNet. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us on today. Now, allow me a moment to introduce our platform, ClearNet. It stands as one of the largest live digital CME platform in India, providing a space for doctors to create and share their medical content. Now, it is my proud privilege to introduce our distinguished leader in the field of anesthesiology, Dr. A.L. Meenakshi Sundaram sir, who is an accomplished medical professional with a vast experience in clinical practice, administration, and medical education. Holding an MBBS, DA, and MD, Sir has served as administrator in government medical colleges across Theni and Chennai, and as a professor of anesthesiology at uh, Thanjavur Medical College. Sir has played a pivotal role in shaping anesthesiology in India, having served as the National Vice President of the Indian Society of Anesthesiologists in 2016 and as a National Governing Council member from 2009 to 2012. Additionally, Sir has held leadership positions as the President of ISA Tamil Nadu State Branch and State Secretary. So, with a rich legacy of contribution to education, research, and organizational leadership, Sir continues to be a guiding force in advancing anesthesiology and medical training in India. So, without any further ado, I would like to introduce today's topic. The focus is ventilation strategies, laser in airway surgeries. So, without any further delay, sir, I would like to hand over this session to you. Please proceed with your talk, sir. Over to you.
Thanks, Mr. Clarnet, a scientific platform for sharing knowledge. At the outset, I request our President, Puthukkottai ISA City Branch, Dr. Munian, to offer his presidential address.
Good evening to all. Good evening to all. Dr. Mamata, Associate Professor of Anesthesiology, Department of Medical Anesthesiology, Bangalore Medical College Research Center. Dr. Shoba, Bangalore Medical College. Dr. Priyanka, PG student, Bangalore Medical College. And moderator, Dr. Dr.Harsoor, Professor of Anesthesiology, Bangalore Medical College and Research Institute. Sir, welcome, sir. Today we are conducting. Good evening, sir. Our academic chairman, Dr. A. Meenakshi sundaram, sir. Today we are conducting second edition of third topic of Puthukkottai Bhudhan, which is conducted by ISS Puthukkottai City Branch. Welcome, sir, for this program. The anesthesia for laser airway surgery is the best topic, which will be presented by Dr. Mamata, Associate Professor of Anesthesiology. It involves safe and secure airway and adequate ventilation, maintaining depth of anesthesia. Also, our goal to prevent fire, damage to the healthy tissue, injury to the healthcare provider who are working in the operation theatre. Madam will give elaborate lecture on the anesthesia for laser airway surgery. Welcome, madam.
Thank you, sir.
Dr. Munian, your internet is unstable. Dr. Munian? Yeah, I think his internet is unstable. So without waiting, we will go to the scientific session. See, as a thematic address, as academic chairman of this ISA Puthukkottai City Branch, I welcome all of you because this is a second group of faculty from Bangalore Medical College, and we are happy to have Dr. Mamata Madam, Assistant Professor, Department of Anesthesiology, and she has done MBBS from Bangalore Medical College and a DA from Kempagoda and a DPNB from Kidwai. So Madam has so many publications in national journals, and the thing is, she has won the first prize in 1 minute award category. So that just because she has won award in 1 minute category, she is not supposed to finish her lecture within 1 minute here. That is my request, because she may be thinking that winning a prize, she may be doing anything. And she has delivered a talk on trauma and coagulopathy and airway. Madam was a chairperson in so many ISACON Karnataka state conferences. And the thing is, she has trained lay people in COLS. That is important. Rather than training the medical people, she has trained the lay people also. And her area of interest is onco anesthesia. Even we are going to have one session on onco anesthesia. And she has won the first prize in group performance of cultural programs. My idea is, whenever an anesthesiologist delivering a lecture here, we have to project their extracurricular knowledge. And Madam, more than this cultural performance, Madam is a yoga teacher, yoga practitioner, and she listened to Kannada songs. Probably she will sing a Kannada song, one song at the end for us in this, because we have not listened to Kannada songs, even Cine songs, we are not aware. Telugu we heard, Malayalam we heard, but I don't know why it had happened like that. Kannada songs we are not exposed to, even Kannada actors we are not exposed to till this Allu Arjun came. So Madam will sing a song so that we will be attracted to Kannada music. And another assistant professor we have is Dr. Shoba. And Dr. Shoba, I have to personally thank her, because she only had a good communication about this session with me continuously. Even small mistakes we will correct. It is very difficult to get a concurrence from her for the flyer proof. Even after the flyer is confirmed, she is coming with the 3 more suggestions. So that sort of a perfection. And Madam is married, PG is yet to be married, but Madam is married having 2 kids. And Madam will take excuse under the name of Dr.Harsoor. So she knows how to tap my potential. She will always say, sir, Dr.Harsoor sir said to do like this. Dr.Harsoor sir said to do like this. Anyway, I will listen to her more than Dr.Harsoor. She is not aware of that. So I corrected even small mistakes, what Madam has pointed out. And Madam is also a faculty in ISACON Karnataka. So she has become a judge also. She was acting as a judge also for the paper presentation. And Madam likes to cook and bake. So this, I think a majority of the people in Karnataka, lady doctors, they are good in cooking and baking. So Madam is baking very well, and she baking of this CME also is done by her very well. So both sides she is backing up. So I like Madam to continue the same. To continue this sort of a CME, I welcome you, Madam. And now the junior most practitioner, Dr. Priyanka, who felt so shy to talk about her. Even the way in which she felt shy, I thought here afterwards from the next session onwards, we can say the speakers has to introduce themselves. So that's sort of a rule we have to frame. And Dr. Priyanka, first thing, she is yet to be married, because nearly 700 people will be witnessing this program. So they will take the message. It will be a carry forward message. She's from UG from Raichur Medical College. And see, she is a good throw ball player. She is a district level player. So anybody who is going to be a spouse of her, he should be very careful. She is a good throw ball player. So he should act accordingly, knowing that. And she is a vice president of the Junior Doctors Association during during her MBBS days. So that means she will raise voice against any act of non-bearable activities. She will raise her voice. So that is also a word of caution. So she is a tough lady, and she has organized various camps, mainly the diabetic camp and eye camps in her village. So she is giving back to the society, and she has won so many prizes in school and college, in quiz competition, essay competition, like things. So I recollect my journey also like this, but I am never, I have throw anything. I have never been a throw one player or this one. So Madam is also, she is interested in all ING, cooking, baking, reading, writing, so everything. And we are happy to have her as a faculty here. And our secretary has joined now. So after the secretary's report, we will hand over the session to Dr. Harsoor, moderator, sir. But to control all these 3 people, the efficient man and one of the handsome, efficient anesthesiologists in India, Dr. Harsoor. I don't know how he was picked up by Dr. Shoba. Suddenly she said Dr. Harsoor will be the moderator. It was a real big surprise for me because he is such a top man. See, he is the past editor of Indian Journal of Anesthesiology who has shaped the Indian Journal of Anesthesiology in the correct format. He maintains the highest standard. See, he was preceded by Dr. Kotur from Karnataka and followed by Dr. Balabhaskar from Karnataka. They shaped editorship very well. And now I want to tell you one thing. We, Dr. Harsoor, Dr. Balabhaskar and myself were the judge in, I think it is Nagra or somewhere. We are the judge for the presentation, PG paper presentation. See, to my surprise, the lady who got the first prize got first marks from everyone. All the three judged her. Even Dr. Balabhaskar said, sir, we need not total it. See, he said that is a common sense. He said, sir, we need not total it. She won the first mark in my judgment also, Dr. Harsoor's judgment also, and Dr. Balabhaskar judgment also. So there is no need to add the marks. It is going to be only one prize. See, at that time, I thought great men will think alike. Anyway, I join myself with Dr. Harsoor and Balabhaskar. Great men think alike. See, all the three, what I want to convey, we were never influenced by anyone. We were never influenced by anyone. Even my candidates were there. Dr. Harsoor's candidates were there. Balabhaskar candidates were there. But we never saw he is such a tough man. And he is the past president of Indian Society of Anesthesiologists. So he is such a great man. Now he is, even after he is retired, he was a DME. See, he was a DME, that is the highest cadre possible in the government side. And this side, anesthesia association wise, presidentship is the highest honor. So both sides he has achieved. And even after retirement, see, he wants to be active so that he is attached to a medical college. This is just to educate. See, such a top man coming to modern session of the June, that too conducted by June City Branch, small city branch, Puthukkottai Bhudhan. It is a real honor, and I think he is a topmost person to moderate this. And I now request Dr. Kannan to address the gathering, secretary's address.
Good evening, all. Can you hear me, sir?
Yes.
Good evening, all. Successfully, we are conducting third webinar of second edition of Puthukkottai Bhudhan. Today, our topic is laser and airway surgeries and ventilation strategies. I welcome Dr. S.S. Harsoor, Professor, Department of Anesthesiology, Dr. Ambedkar Medical College and Hospital, and Dr. Priyanka, postgraduate, and Dr. Mamata, Assistant Professor, and Dr. Shoba, Assistant Professor, Bangalore Medical College and Hospital. Thank you very much, sir. Now we can start the session, sir.
Meenakshi, you are muted. Just unmute.
The session handed over to Dr. Harsoor, moderator, sir. Please take over.
So thank you, everyone. Thank you, Dr. Meenakshi. At the outset, I would like to thank the Clinic Association who are providing a scientific platform to all of us. And at this outset, I think I would like to immensely thank Meenakshi Sundaram for having continuously providing this services, so that the young, talented speakers are brought out, as well as he's propagating the education to various, the participants, nearly about 500 to 700 every time. That's a great achievement, Meenakshi. It was a great job done. We compliment you, congratulate you. Please continue to do that. At the same time, I would like to thank Dr. Munian, the president, and as well as the secretary Kannan, and Madam Hema, Madam. Thank you very much for providing the platform to us, the Bangalore Medical College, and we feel proud and I feel honored to be moderating this session. And today it's a very interesting topic because airway, the moment the word comes, then the anesthesiologist goes into a top care, because it's a very sensitive area where the two people will be the anesthesiologist and the airway surgeon will be working in a very, very narrow area, and also where the margin of safety is so narrow. very, very limited margin of safety. We have to work precisely and meticulously. So in such a situation, the experience as well as the knowledge of the person who is conducting anesthesia is very, very essential. So to that extent, we have got two experienced speakers which are supported by a young and dynamic Dr. Priyanka. So Shoba and Mamata, both of them, I had the pleasure of working with those two persons. Their talent was unlimited and their knowledge is unlimited. So without wasting much time, I start the session with Dr. Priyanka. She is going to speak about the HFNO, the high flow nasal oxygen, and its utility in our anesthesia practice. So, Priyanka, are you ready to start your session?
Yes, sir, I'm ready, sir.
Please. And all the three speakers will be making their presentations, and the participants can, if there are any doubts, clarifications, suggestions, all these things are welcome, and we will be taking up one by one at the end of the session. Collectively, we will be answering both myself, Meenakshi Sundaram, as well as the speakers and any of the subject experts who have got experience in this particular specialty and the field of anesthesia. They're also free to participate and share their views. Over to Dr. Priyanka.
Thank you, sir. Good evening. Welcome to everybody. Myself, Dr. Priyanka D S, postgraduate student, Department of Anesthesiology, Bangalore Medical College and Research Institute. Firstly, I would like to thank Dr. Meenakshi Sundaram, sir, Dr.Harsoor, sir, Dr. Netra SS ma'am, our HOD, and our entire department for this opportunity and the constant support and guidance. Today, I'll be speaking about high flow nasal oxygen therapy. It was first introduced in 1999, mainly for the treatment of apnea of prematurity. It was later on approved by FDA in 2000. Though it has been in market since many years, it gained its popularity in the recent COVID-19 pandemic. It is a type of non-invasive respiratory support which comes in between the non-rebreathing face mask and non-invasive ventilatory support. It basically delivers heated, humidified, and high flow of air and gas mixture via nasal interface. As seen in this picture, HFNO offers many physiological benefits which can be exploited for the better patient management in anesthesia and critical care practice. Firstly, increase in apneic time and carbon dioxide clearance. THRIVE, that is transnasal humidified rapid insufflation ventilatory exchange via HFNO. It is a technique of apneic oxygenation. It helps to extend apneic window by up to 22 minutes and reduces the rate of carbon dioxide rise as compared to the no desat method of apneic oxygenation via simple nasal cannula. HFNO offers relative humidity of nearly 100% with gas warm to 34 to 37 degrees Celsius. It improves patient tolerance by reducing the sensation of respiratory distress and mouth dryness. It improves mucociliary clearance and inspiratory flow, which further increases the feeling of patient's comfort. It diminishes the resistance in the nasal mucosa induced by the dry and cool gases. And fixed FiO2 on dead space washout, as seen in this picture, which is a pictorial depiction of the low flow oxygen delivery system. Patient is put on 4 to 6 liters of oxygen with 100% FiO2, whereas patient's inspiratory demand is up to 35 liters. To compensate for that, there is entrainment of atmospheric air with FiO2 of 21%, resulting in dilution of FiO2 and variable FiO2 delivered to the patient, which does not cater to the patient's demand. Whereas in the high flow system shown in this picture, we can set up to the patient to meet the patient's requirement, that is up to 35 liters with FiO2 of nearly 100%. Because of little or no entrainment of the environmental air, set FiO2 will be delivered to the patient so that hypoxemia will be improved and patient's work of breathing and metabolic cost of respiration will be reduced. HFNO provides positive airway pressure of approximately 1 centimeter of water per 10 liters per minute flow rate with mouth closed breathing. It doesn't produce positive airway pressure throughout the respiratory cycle simultaneously. Thus, it produces only CPAP-like effect. It prevents pharyngeal collapse. It provides positive pressure during expiration, which prevents further small airway collapse called stenting effect. It increases the expiration time and reduces auto-PEEP. It reduces the patient's work of breathing. It reduces preload by increasing the intrathoracic pressure. So when patient is put on HFNO, hypotension is expected. To summarize the physiological benefits as shown in this picture, high flows with high FiO2 is delivered via HFNO, creates positive airway pressure and flushes out the carbon dioxide in the dead space and fills it with the oxygen-rich gases. Cardiogenic oscillation and mass flow of oxygen are the two main phenomena responsible for exchange of alveolar gases across the alveolar and capillary membrane as seen in the apneic oxygenation. HFNO can be used in various methods, mainly in anesthesia for the management of difficult airway. It gives us the luxury of time to switch to the other method of securing airway by decreasing the morbidity associated with hypoxemia. And it can also be used for oxygenation during awake fiber optic intubation, awake emergency tracheostomy. In obstetric anesthesia and AV management in obese patients, to provide unobscured and uninterrupted surgical field while maintaining balanced anesthesia in tubeless field surgeries, to maintain better oxygenation in procedural sedation like ERCP and endoscopic procedures, in postoperative period in high-risk and obese patients following cardiac and thoracic surgeries, in post-extubation as an adjunct to the alveolar recurrent maneuvers, and it also helps to reduce the incidence of re-intubation because of hypoxemia in post-extubation. In critical care, it can be used for the management of hypoxemic respiratory failure due to various causes, in pre-intubation oxygenation, post-extubation, in the management of sleep apnea, do not intubate in terminally ill patients, in mild to moderate ARDS management due to various causes, including COVID-19 infections. It is contraindicated in patients with epistaxis, altered sensorium, upper airway obstruction, skull base fractures, facial trauma, and risk of aspiration. The complications associated with HFNO are limited, which includes abdominal distension, pressure areas, blocked HFNC because of excessive secretions, and pneumothorax. I'd like to stress on the point that when patient is put on HFNO, we should ask them to breathe with keeping the mouth open to reduce the complications associated with volutrauma and barotrauma because of the high flows and high pressures. So how to choose the right cannula size? As seen in this picture, the right cannula should not occlude more than 50% of the nace. If it occludes more than 50% of the nace, then there is less space available for exhalation and leading to carbon dioxide retention. For adults, the cannula comes in 3 sizes, that is small, medium, and large. And for pediatrics, the cannulas are color-coded with red, yellow, purple, and green with the maximum flow rate of 8, 12, 20, and 25 liters per minute simultaneously, respectively. Now we'll see the live demonstration of the HFNO settings. This is the HFNO machine with central oxygen supply. This is the flow sensor. This is the humidifier with the distilled water always filled up to the mark shown here. Underneath the humidifier is the aluminum plate which gets warmed up, and the temperature will be transmitted to the air gas mixture in the air blender. This is the inspiratory tubing, which has temperature probe and heat sensor inside it to maintain the temperature along the flow. This is the patient's interface with soft and pliable nasal cannula. To switch on this monitor, we have to press this long power button long time. Basically, it has 4 settings. To unlock this, we have to press the rotatory knob over the power button, and then we can set it for adult and pediatric age group. Then to increase the FiO2, we have to switch on the flow meter to achieve a desired FiO2. Then we can increase or decrease the flow rates according to the patient's requirement from 10 to 60 liters per minute, and temperature according to the patient's body temperature. Once all the 4 settings are done, we have to press this button to start the HFNC. Then when should we wean the patient from HFNC? When patient's flow rate reaches less than 20 liters per minute and FiO2 is less than 40%, we can wean the patient from HFNC to low flow oxygen delivery system like simple face mask or nasal cannula. To monitor the effectiveness of HFNC, the ROX index is used, which is measured by saturation divided by FiO2 into respiratory rate. If it is more than 4.88 after 2 hours of treatment, that means patient is improving. If it is less than 3.85, there is higher risk of treatment failure. If there is no improvement even after 60 to 120 minutes, then treatment escalation like invasive ventilation, intubation and ventilation must be considered. There's a famous trial called Florali trial, which is done to know the effectiveness of high flow oxygen through nasal cannula in acute hypoxemic respiratory failure. The results are that high flow oxygen via nasal cannula is non-inferior to oxygen delivered by a non-rebreather face mask and BiPAP in reducing the subsequent need for intubation. It reduces ICU and 90-day mortality compared with the other strategies. It also subjectively improves dyspnea and respiratory discomfort at 1 hour compared with the other oxygen delivery devices. Further studies are required to know its effectiveness in management of ARDS because of various other causes. Thank you for the patient listening.
Thank you, Dr. Priyanka. That was an excellent presentation, and you have done a very nice demonstration of how a HFNO unit can be used in our clinical practice. That's, and a lot of improvements have taken place ever since the COVID, because before COVID, it was considered as a luxury and an expensive equipment, but COVID has changed the system completely, and its utilization in anesthesia has improved over that period.
Yes.
Thank you very much. And any questions, we will take it. You are free to, the participants are free to post their questions in the question chat box. Shall we move on to the next talk by Dr. Shoba?
Yes, sir.
Okay.
Right. Okay.
Good evening to all. Myself, Dr. Shoba, bring the warm greetings from Bangalore Medical College and Research Institute. I would like to thank Dr. Meenakshi Sundaram, sir, the academic chairman of Puthukkottai branch, for giving me this opportunity to present in this webinar. So thanking all my mentors. So let's start on how to go about the jet ventilation in OR. There is no proprietary or commercial interest in any product mentioned. So I'll be dealing on these headings. The challenges that we face with the maxillofacial or the laryngotracheal surgery is how to manage potentially difficult airway, the sharing of airway, the optimal surgical access with the still operative field. So one of the modality for this is the jet ventilation. So where it enables the gas delivery at multiple points along the airway. So jet ventilation, it's a delivery of the high pressure gas bolus via a narrow bore devices, so which encourages the entrainment of air by the Venturi effect. So by increasing the delivered tidal volume and hence the ventilation. So basically we are going to provide a tidal volume of 1 to 3 ml per kg, which is less than the dead space at 1 to 10 hertz, followed by the passive expiration without an endotracheal tube. So how is the jet frequency ventilation being classified? So we have the high frequency positive pressure ventilation, so which has become obsolete, the high frequency percussive ventilation, and we have the high frequency oscillatory ventilation. So this is the one that is basically used in NICU to ventilate the teeny-weeny immature lungs at a rate of 300 to 1,800 breaths per minute. And here there is the active expiration, which is C. And jet ventilation, according to the breaths we are going to give, it's being classified as high, low, or a combination of both is the superimposed high frequency jet ventilation. So jet ventilation is a versatile, safe, effective technique with growing indications for the elective and emergency use, so which was described by Klein and Smith in 1977. So today I'm going to highlight on the basic science necessary to practice jet ventilation safely, increase the familiarity with the equipment and the techniques used in OR. So what are the indications? So one is to facilitate the surgical access, so which can be, it cannot intubate, cannot ventilate scenarios like in emergency conditions or in elective conditions like if there is an anticipated difficult airway, so using pre-operative placement of it, or in direct laryngobronchoscopy for the foreign body retrieval, or any surgeries on the vocal cord, airway, or thorax, or in one lung ventilation, where by applying the jet on the non-dependent lung, it will decrease the shunt fraction. So the other indication is in optimizing the pulmonary function. So where we can reduce the leak as in bronchopleural or tracheoesophageal fistula, the laryngeal neoplasms, barotrauma, severe ARDS, and so. Is there any absolute contraindication for jet ventilation? No. But some of the relative contraindications are, so when you can place a definitive airway more easily, there is a complete upper airway obstruction distal to the vocal cords, a foreign body which may be distally lodged, severe tracheal stenosis, so where there is a risk of aspiration, or in morbid obesity, so where the chances of airway collapse can happen. So it's based on the principles of Bernoulli's, so which states that a stream of gas at high flow creates an area of low pressure, which will entrain the surrounding air and provide the alveolar ventilation. So here we can see the entrainment of air in the supraglottic jet ventilation. And in subglottic and the transtracheal jet ventilation, so below this is the vocal cords. So below that, there is the entrainment of the air happening. So way back in 1915, the physicist Henderson, he saw a dog panting with a low tidal volume and a higher frequency. So, which showed that the dog was neither hypoxic nor hypercapnic. So there was some kind of mechanism in the gas exchange which was happening. And it was a study by Dworkin et al. In 1990 who determined the critical diameter jetting across a glottis that's less than 4 to 4.5 mm in diameter leads to gas trapping, so which occurs independent of the jet ventilation settings. So here, as the tracheal diameter decreases, the time for the expiration increases. So there is some of the principles of the gas exchange which happens are the convective blood bulk flow, the laminar flow, the Taylor dispersion, pendulum effect, the cardiogenic mixing, and the molecular diffusion. So cardiogenic mixing is basically because of the contraction of the ventricles adjacent to the lungs. There is a mixing of the gas and the gas exchange happens. And as we know, molecular diffusion is basically from the higher concentration to the lower concentration, the oxygen moves. In the bulk convection, so more gas is entrained into the alveoli by the vacuum that's left when the oxygen is absorbed into the capillaries. In pendulum effect, it basically depends upon the time constant, which is a product between the compliance and the resistance. So these one part of the lung, it has a different time constant from the other part or from the one alveoli to the other alveoli. So the gas fills one of the alveoli more faster than the other, and it moves from there to the other alveoli with a different compliance. So there is again the mixing of the gas and the gaseous exchange happens here. In Taylor dispersion, the jet gas which moves into the airway has a higher oxygen concentration than at the peripheries. So this again brings about the gaseous exchange. As the jet force is high, at the same time, there is a coaxial flow where the carbon dioxide moves out along the peripheries of the airway. So this is a picture which shows the inflow of the oxygen and the carbon dioxide moving out simultaneously. So there is the coaxial flow happening. So what do we need here? So we need a high pressure oxygen air source at 50 psi, a control system to regulate the flow. So that is a ventilator or a handheld device, and a channel to direct the gas in the form of a catheter or the cannula. So what are the different types of jet ventilation? So as I said, we have the low frequency that's less than 60 jets per minute, which is given by these Manujet or the Sanders injectors. High frequency, more than 60 by Monsoon or the Yvonne jet ventilator. Superimposes both high and low frequency by the spin stream ventilator. So coming to the high frequency jet ventilation. So this is a time cycled pressure limited ventilation. So it's an open ventilation system, does not require an expiratory valve. So these automated devices has many added safety features than the handheld devices. So what are all the parameters that's going to be set here? We have the rate in hertz. Hertz is 1 hertz means it's 1 cycle per second. So per minute, it's going to be 60. So oscillation is the one usually we put it in hertz. So otherwise, its breath is what we put for the jet ventilation. The inspiratory time, the percentage of the total cycle time spent in inspiration. Driving pressure is the emission pressure of jet pulse, 0.3 to 3.5 bar. And the FiO2. FiO2, it depends on the entrainment of the oxygen. So what we set will be different and what the patient delivers will be different. And we are also going to set the alarms. We have the pause pressure, so which is the pressure at which the ventilator stops jetting. So which is measured from the tip of this high frequency jet ventilator catheter, which reflects the pressure inside the airway, which approximates the mean airway pressure. And we are also going to set the peak inspiratory pressure, the end expiratory pressure at the peak. So to quote an example, what if the ventilator is a monsoon? So what all we need here? We need an oxygen, air, the power supply, the oxygen splitter, jet ventilation tubing, jet ventilation catheter, and the test lung, basically for the safety test. So here there is a clipping which shows how to set the ventilator. So the air and the oxygen supply, it's connected to the pipeline. If there is no air, you can have an external compressor. Use sterile water for the humidification. There's 2 tubings. The blue is for the jet ventilation. The red is for the pressure monitoring. And these are being connected by the Leolock mechanism to the test lung. So make sure when we connect, the air is completely purged out of the tubings. So how do we set this up? So once it is being connected, this is the drop sensor. When there is no drop falling into it, again, it will give an alarm. So make sure these tubings are connected before the ventilator is put on. So priming of the ventilator is being done by setting the humidification, usually at the level of 4. There is an opening. There is an opening which is present on the connector of the test tube, test lung. So which shows basically the safety feature. So that is by occluding the opening, will test the ventilator's ability to detect the high pressure. And this also ensures that the tubing has no leaks. So as pressure builds, the apparatus will suspend ventilation at the pressure limit and the notification high peak inspiratory pressure will appear. So what are all the parameters that's going to be set here? The driving pressure, the frequency, the inspiratory time, the pause pressure, the width, the oxygen, the bypass flow, and the humidity. So make sure you dehumidify the ventilator before it is being switched off, because the presence of the water within it will be a source for the bacterial growth. So that's one of the safety tests which was done. The other one is, instead of occluding the opening, we can also occlude this second lever connector and the test lung outlet, which inflates the pause pressure from 0. So when the pause pressure reaches the alarm pressure, which will sound and it will stop jetting. So releasing this, it will resume the jetting. So these are some of the recommended settings for the high frequency jet ventilation. The decompressed air that is being supplied, it basically brings down the temperature of the gas by almost 15 degrees centigrade, so which can cause hypothermia. So we deliver the heated and the humidified jets of air that are interrupted by an electrical solenoid valve. So usually when the procedure goes beyond like 4 hours or in the ICU, this can be used. And high level of humidification increases the airway resistance, so that's to be avoided, otherwise we'll be flooding the lungs with the water. So the next one, which is superimposed along with the high frequency, is the low frequency jet ventilation, which is a bi-level mode of ventilation. So the main goal of adding this is to increase the minute ventilation and improve the carbon dioxide removal by improving the lung recruitment, which leads to the better oxygenation. So this basically controls the PEEP and the plateau pressure. So here there is a two tubings which is present, the low and the high frequency that's connected to the rigid bronchoscope. The illustration of a superimposed jet ventilation, where the positive pressure, the PEEP that's being provided by the low frequency jet ventilation, which recruits the alveoli. So better oxygenation, in turn, better ventilation also. So along with this, there is high frequency jet ventilation that's given. So the difference between these two will be your tidal volume. So whenever we are going to start, always start with a lower value and increase the parameters depending on the end tidal carbon dioxide or the PaCO2. Look at the chest expansion, the saturation, and clinically observe for the color of the patient and auscultate. ABG sampling can be used to guide ventilation in highly symptomatic patients. So now coming to the low frequency jet ventilation. So these are manually operated jet ventilation devices, so which delivers high pressure gas via a narrow cannula device at a frequency of 10 to 20 breaths per minute and at 10 to 15 liters per minute. So inspiration will be usually for a second and expiration for 4 to 5 seconds. So usually used for short procedures because there is no capnography. We should be very meticulous in observing for the clinical signs of a patent airway and consideration of the hypercapnia. So this is the Manujet 3. So some of the parts of this is, it has a connecting tube which is 100 centimeter long with a Leo lock which gets connected to the catheter. We have the trigger for on-off manual activation, the pressure regulator for with the locking mechanism, and we have the gauge which is color coded, the green for the infants, yellow for the children, and red for the adults, given in bar and PSI, and pressure hose which is 4 meter long for connection to the central source or the oxygen cylinder. So to reduce the risk of barotrauma, so there must be a route for the passive exhalation. So we should either provide the jaw thrust or insert a supraglottic airway devices or the nasopharyngeal or the oropharyngeal airway to maintain the upper airway patency while jetting. So here there is a video to show how the Sanders works. So you're going to identify for the cricothyroid membrane with the Revusin needle and confirming the presence of air once it enters into the trachea, secure it and connect by the Leo lock mechanism to the handheld device. And once you decide on the pressure, lock it and you can ventilate the patient. So all these were basically the passive expiration, so which had chances of barotrauma. So one of the latest relatively new device is the Ventrain, so where there is the active expiration using the suction and the Bernoulli's effect. So it is a flow control device where the inspirated tidal volume can easily be estimated from the set flow and the inspiratory time. So if the flow is set at 6 liters per minute example, so inspiration will be around 100 ml in a second. So this is a flow chart, table which shows the flow and the volume that's administered per time. So this is how it functions. It looks actually simple, but the person should be very cautious enough when he is handling the device. These has two holes where we will be occluding with the thumb and the index finger. When both is occluded, it causes the inspiration. When the thumb is released, it causes the expiration. So this both has to be done for a cycle of 5, and following which a pause of 5 seconds is given to bring about the equilibration. So that is to bring about the intrapulmonary pressure to that of the atmospheric pressure. So that is basically the passive exhalation, what happens during that time. So it's the same thing, how it operates. So you need training to safely use this, and you should have an hand-eye coordination when you're using it. So again, a small clipping on the membrane. So you're going to basically connect it to the test lump and to the pressure monitoring. So it has two openings. When you close both, it causes an inspiration. Opening the thumb causes expiration, and both when it's opened, it causes the equilibration. So you can adjust the pressure accordingly. So these are some of the settings for the low frequency jet ventilation and the superimposed high frequency jet ventilation. What are the troubleshooting and how do we manage this? So one of the troubleshooting is we have hypoxia. If it is not a laser surgery, we can increase the FiO2. Check for the jet ventilation, the catheter and the jet line for any obstruction or kinking. So consider reparalysis if the patient is breathing. Auscultate the chest prior to change of any other parameters by ruling out the pneumothorax. And manuals to increase the FRC by giving a proper position or increasing the driving pressure, the frequency, or the inspiratory time. If the hypoxia is still not improving, maybe we might have to abandon the jet ventilation and go on for the conventional mechanical mode with the endotracheal tube. So in hypercapnia, what do we do? Basically, we are going to increase the driving pressure, so which will remove the carbon dioxide. And in conventional ventilation, if there is increase in the PaCO2, basically we will increase the rate or we will increase the expiratory time. But by doing so, the time for the expiration is going to be reduced. So you are going to come down with the rate and the inspiratory time here. So what are the different routes of the delivery? So we have the supraglottic, where the catheter is being placed, proximal above the vocal cords, subglottic, it's inserted below the vocal cords under direct vision. So transtracheal, the cannula is inserted through the cricothyroid membrane. So what are the advantages we have? Supraglottic, we have the optimal surgical access. In subglottic, it has the ability to monitor the end-tidal carbon dioxide and with minimal vocal cord movement. So transtracheal, the pre-induction insertion assists in difficult airway management. The disadvantages of these supraglottic, your inability to measure the end-tidal carbon dioxide, and there is a vocal cord movement. So out of the barotrauma, the more so is seen with the transtracheal, and also there is a risk of catheter obstruction and the dislodgement. So coming to the jet ventilation catheters. So this is a Hunsaker Monjet ventilation tube, which is made up of Teflon, safe for the laser surgery, except for the cage. So the cage, it aims to center the tube within the airway to reduce the risk of mucosal injury. So it's a flexible structure integrated with the monitoring lines, which allows the airway pressure and the carbon dioxide monitoring. This is a Mistral jet ventilation catheter where the length of this can be adjusted accordingly to the type of the surgery. The subglottic catheter is introduced to a depth of 6 to 8 centimeter distal to the vocal cords or 3 to 4 centimeter above the carina. Again, a video which shows how the double lumen jet ventilator is going to be inserted. So once the patient is adequately paralyzed, you will be using the topical anesthetic for the stress response. And then the double lumen jet catheter is being introduced under direct vision, and it's placed on one of the angle of the mouth. It's being connected to the jet and the pressure monitoring also. So following this, just look for the chest excursion. If it's not adequate, maybe the parameters can be changed accordingly. And this shows the heated and the humidified gas that's given. The transtracheal catheter, we have the Revusin jet ventilating catheter, which is a curved one with a 15 mm connector, which permits a connection directly to the breathing circuit, which can be used in emergency situations. Cooked transtracheal catheter, so which is a kink resistant. We have the ARLT emergency cricothyrotomy catheter, which is again a pre-curved kink resistant, so which is introduced by the Selvinger's technique. So this is how the transtracheal jet ventilation catheter will be placed. So sometimes the jet port can be paired with the conventional mechanical ventilation through an life port adapter. So which is usually done in the critical care setups. So apart from this, now coming to the monitoring. So ECG, the non-invasive blood pressure, the pulse oximetry, end-tidal carbon dioxide, transcutaneous carbon dioxide, repetitive blood gas analysis if needed, the peak airway pressures, and we have to observe for the thoracic excursions, the skin color, and the chest auscultation. What are the advantages? We have a tubeless field, which reduces the risk of the airway fire. Jet ventilators, it can be used along with the conventional endotracheal tube. It's an open breathing system, so no airtight connection is needed here. So there is less bronchial and the mediastinal excursion. It gives a better access to the surgeons to operate, so obviously the duration of the surgery will come down. The disadvantages, there is no protection against the soiling. You are unable to measure the airway pressure, and we are not able to deliver the volatile gases, so it's going to be TIVA. High driving pressure will cause a barotrauma, the pneumothorax, or the pneumomediastinum. There is a risk of hypercapnia and inadequate gas exchange, the potential to dislodge catheter, and the dry gas, if it's given for a longer duration, there's chances of the mucosal trauma. So role of jet ventilation in difficult intubation algorithm. According to DAS guidelines in 2004, in unanticipated difficult intubation, it was included in can't intubate, can't ventilate scenarios. But later it was removed and it was more simplified way of the scalpel bougie tube technique was introduced. But the use of this overall is being declined because of the advances in the non-invasive airway device, such as a supraglottic airway and the video laryngoscopes. So what are the concerns? So it's prudent to begin at a low driving pressure and increase it in increments to observe the rise and fall of the chest. Inadequate ventilation could lead to hypercarbia, so keep the upper airway open. It's crucial to align the jet along the axis of the airway. If not, it leads to subcutaneous emphysema and pneumomediastinum. The failure of adequate exhalation results in stacking of the tidal volume and raising the intrathoracic pressure, which leads to the cardiorespiratory collapse and also causes increase in the ICP. So one of the solution is the ventrain, which brings about the active expiration. The anesthetic technique. So standard monitoring with the adequate pre-oxygenation. General anesthesia provides amnesia and better hemodynamic stability. So TIVA with the short-acting agents. Lignocaine spray can be used for inserting the bronchoscopy. Deep muscle relaxation ensures excellent condition during the entire procedure and must be completely recovered before extubation. And it requires a permanent presence of an anesthesiologist who is well versed with the jet ventilation. We are going to maintain this because of the high chance of intraoperative awareness. The transcutaneous carbon dioxide, it allows a reliable, non-invasive estimation of the PaCO2. So up to 1.5 times the baseline can be tolerated at the end of the surgery. So alternatively, the ventilation can be achieved via a laryngeal mask until the airway is open and the high frequency jet ventilation can commence. Increase in the inspiratory time and the frequency improves the oxygenation, and increase in the driving pressure and decrease in the frequency improves the ventilation. So with the completion of the surgery and a good respiratory effort, the jet ventilation can be switched off and supplemental oxygen delivered via a bag in the mask and the catheter removed in the same way as a standard endotracheal tube. So sometimes we can ask for the post-op chest X-ray when you had a difficulty in ventilating, anticipated or you thought of a barotrauma or carbon dioxide retention. The further application of the jet ventilation, it's basically because of its ability to reduce the ventilation-related movement in some of these fields, as in hepatobiliary, where it reduces from 12 mm to 2 mm the movement of the liver as it's adjacent to the diaphragm. Conclusion. So jet ventilation is an unconventional technique with a steep learning curve and thus demands being used by the trained personnel following a proper assessment of benefit versus risk and with appropriate procedures for monitoring. So every anesthetizing location have jet ventilation equipment and the anesthesiologist becomes familiar with the technique. So clear team communication and pre-procedural planning are required when using jet ventilation to ensure optimal patient outcomes. Some of the quiz questions. The most effective way to increase carbon dioxide elimination is by dash the driving pressure and the frequency. What do we do with the frequency? And one more question, because all the hospitals are not equipped with the jet ventilator. So in absence of a jet ventilator, what are the basic requirements for securing the percutaneous translaryngeal jet ventilation? So you can post the answers in the chat box. These are my references. Thanks for the time and the patience listening.
Okay, thank you, Dr. Shoba. It was an excellent presentation. I think you made the an unconventional topic simplified and done an excellent job. And just to tell you, the slide quality of the slides and all were enhanced with the help of Canva. So I want all the youngsters who are preparing themselves for the presentations, please make use of this artificial intelligence tools so that your quality of images will improve, the quality of a presentation will definitely go up. Tools like Canva will help increase the infographics, as well as Gamma app is another one which is coming in a big way, helping us. So any questions and the answers to the question what she has posed will be maybe posted in the chat box. We'll take up at the end. And for now, we will move on to the next speaker, Dr. Mamata, who is an assistant professor once again at the Bangalore Medical College and Research Institute. Over to you, Dr. Mamata.
Good evening, everyone. I thank the organizing team, Dr. Meenakshi Sundaram sir, for giving me this opportunity. I thank Harsoor sir for moderating this session and putting his valuable inputs. So, the topic for webinar is anesthesia for laser airway surgery. Introduction. Airway surgery demands high level of cooperation between the surgical and the anesthetic team as they're working in the same anatomical field. Laser light is a powerful cutting tool and it makes it dangerous too. It is therefore important for the anesthesiologist to understand the fundamental principles of laser, its application for safe clinical practice. With surgical laser, there can be a risk of airway and non-airway fire, damage to the surrounding LT tissue, and potential injury to the theatre personnel. I'll be dealing under following outlines: the principles of laser, the laser hazards, the general and the airway-related hazards, preventing airway fires, anesthetic technique, anesthetic management, and the take-home message. Let's look at the history. Laser is an acronym for light amplification by stimulated emission of radiation. In 1960, the first functioning laser was constructed by Theodore Niemann in California by using ruby crystal and red light to produce a laser light. Laser is an electro-optical device that emits organized light in a very narrow intense field by a process of optical feedback and amplification. Focalized high energy results in intense coagulation of the tissue, thereby reducing the bleeding and sparing of healthy tissues. Let us see what are the components of laser. It has a lasing media or the gain media, which can be either solid made up of glass or crystals, liquid usually made up of a dye or an organic solvent, gas, it can be either a carbon dioxide or an argon or a semiconductor. And it has a energy source or a power through which the energy is supplied. It can be through a high voltage discharge or through a diode or a flash lamp or another laser, or it can be a chemical reaction. And it has a optical resonator or an optical cavity. This cavity consists of the lasing medium and it has two parallel mirrors on either side, one being highly reflective and the other being partially reflective, allowing some of the light to leave the cavity so as to produce an output beam, that is the laser output, through a process called as output coupler. So it has a unique property. Laser has a unique property. Unlike the ordinary light, which is polychromatic, laser light is monochromatic, made up of single wavelength or color. It is coherent. The photons oscillate synchronously in an identical phase, looking like marching of soldiers. It is cumulated. The photons are almost parallel to one another. They're aligned and with little divergence from the point of origin. Let's see how lasers are classified. Lasers are classified based on their wavelength, power, and their ability or the potential to cause injury to the biological tissue. Are classified into class 1 to class 4. Our medical lasers belong to class 4 and they pose danger to the eye, skin, and combustible materials. They are fire risk and can produce air contaminants and plumes. All class 3B lasers and class 4 lasers must be operated by a trained, authorized personnel and must be equipped with a key switch and a safety interlock. What are the types of medical lasers and their uses? The first constructed laser was the ruby laser, which is used for tattoo and hair removal. It is used by the dermatologist for dermoabrasion, and also for vitiligo treatment. The argon laser is used for corneal surgery, AV malformation, and diabetic retinopathy. The excimer laser, which is a combination which contains argon and fluoride, is used for corneal resurfacing, that is in refractive error correction, that is the LASIK surgeries. Then you have the KTP laser, which is used by the endodontic and also by the ENT surgeons. Then you have the Nd:YAG laser, which has a wavelength of 1064 nanometer. It is used in ENT surgeries. The oleum YAG is used in lithotripsy, and it is also used in laser benign prostatic hypertrophy excision. And you have the carbon dioxide laser with a wavelength of 10,600 nanometer, which comes under the infrared spectrum, and it is invisible and is used in oral surgeries like the leukophakia, cervical and vulval cancer, laryngeal surgeries, and the tracheobronchial surgeries. The tissue interaction with laser. Once the laser beam strikes the tissue, it can be either absorbed, transmitted, reflected, or scattered. And the tissue interaction depends upon the laser wavelength, the power density, and also on the exposure, that is the duration of exposure, the exposure time. So what are the advantages of laser? It acts as a scalpel and electrocoagulator and provides an excellent microscopic precision to the surgeons. It is minimally invasive and completely sterile, and there is low infection rate. It provides a bloodless operating field, aiding in good hemostasis with lower complication when compared to conventional technique. It reduces the tissue damage, helps in preservation of the normal tissue, aiding in wound healing. It causes less post-operative pain, edema, and discomfort. Quicker recovery time with shorter hospital stay and cost effectiveness. What are the common the lasers which are commonly used in airway surgeries are the carbon dioxide laser, the KTP laser, the argon laser, and the Nd:YAG lasers. The common indications being the benign growth such as the opal cord polyp, nodules, cyst, papillomas, and granulomas. And opal cord dysfunction may be due to laryngeal paralysis. The malignant growths of the larynx, trachea, and the bronchus. It is also used in treatment of tracheal stenosis following a trauma or following a corrosion ingestion. Let us see what are the hazards of lasers. The general hazards, it can cause damage to the eye. The direct or the indirect exposure can cause an irreversible serious corneal and retinal injury. It is essential for all the individuals inside the laser operating theater to wear a wavelength specific eye goggles. The patient's eyes must be taped and can be further protected with the saline gauze or with the wavelength specific safety eye goggles and with the metal goggles. Skin and drape damage. The patient exposed area, the face, and the area around the suspension laryngoscope should be protected with wet towels, and drapes. Gas embolisms have been reported with laser excision of the tracheal and the bronchial lesions, and there may be a risk of insertion of flexible fiber carbon dioxide laser into the bronchial tree due to the risk of gas embolism. It is wise to monitor the end-tidal carbon dioxide for the early diagnosis and management. Laser plume. It is the plume of smoke produced by tissue vaporization during laser surgery may contain bioaerosols, cell fragments, blood fragments, viruses, bacteria, which may be hazardous. Smoke contains fine particles ranging from 0.1 micrometer to 0.8 micrometer, which can be efficiently transported and get deposited in the alveoli, thereby impairing the mucociliary clearance, can cause inflammation, bronchiolitis, emphysema, and interstitial pneumonitis. Carbon dioxide laser is known to produce most of the laser plumes, and it is wise to use a high efficiency filtrate mask and a respirator for the protective measures. Misdirected laser can occur because of equipment malfunctioning or due to an inadequate knowledge by the operator. Laser protocol: always set in a standby mode unless it is ready to fire. Use a pulse mode than a continuous mode. Limit the energy and the duration. The airway laser hazards includes the airway fire. This is some of the signages you see on the operating theater door or the wall. The laser surgery should be done in a designated OT, and this sign gives a warning. It informs everyone that the laser is in use and should be entered with the protective equipment to prevent, with the protective measures. In this image is taken from a laser surgery OT. Here you can see the surgeon is operating under the microscope and he is using carbon dioxide laser, and the instruments are matte or dull finish to prevent reflection of the laser light to the non-targeted tissue, and the patient is covered with wet drape to reduce the risk of fire. These are the wavelength specific safety eye goggles. For Ruby, you have the blue goggles. For NDR laser, you have the green goggles. And for carbon dioxide laser, you have the clear or the plastic goggles. And for the KTP or the argon, you have the amber or the orange colored goggles. The second picture shows that the patient's eye is taped with a metal shield. Always have a pre-filled saline syringes in 50 ml and 20 ml, and always have a bucket of water on the operating table, and you have the laser specific mask for the protection of laser plume, and a smoke evacuator should be used by the surgeons to reduce the effects of laser plumes, and always have a carbon dioxide extinguisher inside the OT. So what are the essential components for airway fire? So for the fire to occur, there should be a fuel source, ignition source, and an oxygen source. The fuel source includes the endotracheal tube, the volatile anesthetics, and the ignition source includes the laser itself or the fiber optic light source. The oxygen source includes the oxygen and the nitrous oxide. In this video, you can see when a laser beam strikes the cuff of the endotracheal tube, it gets perforated, punctured, and a flume of smoke develops due to burning of the endotracheal tube. This is almost a similar illustration that happens in airway fire. So what should be your plan of action if an airway fire occurs? Never panic. Stop ventilation, turn off all the anesthetic gases, including oxygen. Extinguish the flame with saline solution. Remove the endotracheal tube after deflating the cuff and ensure the whole of the endotracheal tube is removed. Ventilate the patient lung with face masks with 100% oxygen. Examine the airway for any airway burns or foreign bodies using a video laryngoscopy or a laryngoscopy. Re-establish the airway with supraglottic airway device or an endotracheal tube if needed, and consider ICU admission. These are some of the special endotracheal tubes for airway laser surgery. These are laser resistant tubes and they are not completely laser proof. You have the McIntyre laser flex tube. The shaft is made up of stainless steel spiral and it has a double cuff, the proximal and the distal cuff. If the distal cuff gets punctured, the proximal cuff will protect, and the tip is PVC made. You have the uncuffed tube for the pediatric patient. Next, you have the laser tubers manufactured by the Rush company. The shaft is made up of soft white rubber and a silver foil is wrapped, and it has a merosil sponge within the cuff, and this merosil sponge has to be soaked with saline. This is cuff in cuff arrangement. And next you have the Smith's Binova foam cuff. It has a self-inflating polyurethane cuff and the shaft has a aluminium spiral. And the Medtronic's Zomat laser shield 2 has its shaft is made up of silicone elastomer and it is wrapped with aluminium and Teflon. All the cuffs are flammable and they are not laser proof. The diameter of all the laser tubes, inner diameter of all the laser tubes are smaller due to the insulations and they are very rigid and you need a stylet for incision. All the cuffs should be inflated with saline, as saline acts as a heat sink and it acts as an inbuilt fire extinguisher when the cuff gets ruptured. And you can add an addition of methylene blue so that it helps the surgeon for early detection and management. So what are your concerns? So the surgeon's concern is he has to operate on the airway and he has to share the airway with the anesthetist. For the anesthetist, the airway is compromised to the airway lesion. He has to share the airway with the surgeon and he has to maintain a patent airway. Other concerns. For the surgeons, he needs a good exposure. He needs a smaller endotracheal tube so has to operate efficiently. And he needs a motionless field and the airway should be free of secretion. The concerns for the anesthetist: to maintain oxygenation and ventilation, smooth induction and maintenance of anesthesia with good anesthetic depth, and to maintain a good hemodynamic stability during laryngoscopy and prevents falling of the tracheobronchial tree and prevention of airway fire, and should have a smooth emergence at the end of the surgery. The preoperative evaluation is almost similar. How do you evaluate for any airway surgery? Assessment of cardiorespiratory function is vital for assessment of the effort tolerance, the metabolic equivalence, as this is going to the anesthetic technique changes with the assessment of the cardiorespiratory function. The ideal will give an information about the function of the larynx and also the airway narrowing. The CT MRI will give you the information about the location, extent, the upper and the lower limit of the tumor. The nasal endoscopy, which will help to say what is the size, shape, how is the vascularity, is it fragile, is it polypoidal granulomatous, gives an idea. And the virtual endoscopy is important. It is a non-invasive technique where the CT or the MRI images are used to construct a 3D image of the airway. This will help the anesthetist, especially in a critical airway or a altered airway anatomy, to plan his anesthetic technique and also the ventilation. What will be your preoperative preparations? Always formulate a plan and discuss with the surgeon prior in hand, and always be prepared with a rescue measure. And the anesthesia technique is based on the potential threat to the airway, the expertise, and the available resources. Avoid sedative pre-medicants, as it is going to, there will be a loss of muscle tone and it can hamper the airway obstruction. And always consider a anti-sialagogue with glycopyrrolate to reduce the secretions and also to inhibit the vagal stimulation for the laryngoscopy. And topicalization of the airway will reduce or prevent the airway-related complications. The anesthetist, surgeon, and other staff should work as a team and practice airway fire drill prior in hand. Always keep a difficult airway cart with the tracheostomy set standby. What are the goals of anesthesia? You should have a profound muscle relaxation for introduction of the scope, and you need immobility as the laser beam can misdirect. Maintain adequate oxygenation, ventilation with good anesthetic depth with use of short-acting alpha-2 agonist, lignocaine, and other opioids. Take measures to reduce complications like laryngospasm, laryngeal edema, aspiration, and airway obstruction. And restoration of consciousness at the end of surgery with return of airway reflexes is essential. What will be my anesthetic technique? So anesthetic technique does not exist, and some of this ideal condition may conflict. You might think endotracheal tube is safe, but it can obscure the subglottic lesion, and laser is not safe with the conventional endotracheal tube. For jet ventilation, you require a specialized equipment, knowledge, and expertise to manage it efficiently. So the safe laser airway surgery requires good understanding of the airway pathology, location of the lesion, the type of laser being used, the surgical requirement, what the surgeon requires, and the patient comorbid conditions. Good communication and cooperation before, during, and after the surgery is the key for a favorable outcome. The anesthetic management has two approaches, the open system and the closed system. The technique chosen is not absolute and may change as the surgical and the anesthesia requirement changes. In the non-intubating technique or the tubeless technique, you have the intermittent apneic ventilation, apneic oxygenation, spontaneous breathing, and jet ventilation technique. In the closed or the intubation technique, you have conventional tube using the conventional endotracheal tube with protection, usually wrapped either with the aluminum foil, silver foil, or a muslin cloth, and you have a laser resistant tube, and awake tracheal intubation is done for critical obstruction, and awake tracheostomy is done for almost critically obstructed airway. The advantages of intubation technique are it secures the airway, there's less risk of aspiration, it can optimize the oxygenation and ventilation, you can administer inhaled anesthetic technique, it aids in monitoring of saturation and end-tidal carbon dioxide. The disadvantages or the limitation includes the endotracheal tube can limit the surgical view of the axis, there's risk of airway fire and can cause airway trauma. Due to high airway pressure can lead to barotrauma. Due to the use of smaller endotracheal tube, there can be high airway resistance during ventilation. In the non-intubating or the tubeless technique has an advantage of excellent surgical field, no flammable materials, that is no endotracheal tube in the surgical field. The disadvantages includes impaired oxygenation and ventilation, gastric distension, barotrauma with fluctuating depth of anesthesia and contamination of the OR. In the non-intubation technique, the intermittent apneic technique, here the patient is induced and after induction, patient is intubated and extubated intermittently. When the patient is intubated, patient is hyperventilated, so has to maintain the saturation of 100%. When he is extubated, that is during the period of apnea, the airway is given to the surgeon to introduce the suspension laryngoscopy and to apply the laser. The visibility is excellent and it is safe, laser safe, as there is no fuel source in the airway. But there's risk of aspiration, there is inadequate ventilation, and it is not suitable for patient with patient with poor cardiac and lung status. And there is also limitation of surgical time, and there can be loss of airway. In spontaneous breathing technique, the patient is induced and is ventilated with a face mask and is given to the surgeon to introduce the laryngoscope, and after doing the topicalization of the airway is left spontaneously, and oxygen can be delivered through the side port of the rigid laryngoscope. The visibility is excellent. The vocal cord function can be assessed very well, and it is suitable for patient with a compromised airway and also in pediatric patient. But it is very difficult to assess the oxygenation and ventilation, and the surgical field is mobile. So it can lead to airway-related complications like laryngospasm and the inadequate depth of anesthesia. In jet ventilation, here in this technique, high-pressure gas is delivered to the airway with a jet ventilator, which is aligned to the laryngoscope. It can be supra, sub, or transglottic. The visibility is excellent. There is no risk of airway fire. There can be atraumatic airway manipulations. And you need to maintain the technique with TIVA. The limitations include inadequate gas section can lead to hypoxemia, hypercarbia, barotrauma, it can be pneumomediastinum or pneumothorax. Due to the dry gases, it can cause mucosal injury. This is the Hunsaker subglottic airway device, and this has a port for jet ventilation, and it also has support for airway pressure monitoring and the end-tidal carbon dioxide monitoring. And this part is the basket, the distal part is the basket, and this is not laser proof. The remaining is laser proof. This is the Mistral or the laser jet. The blue is used for jetting, and it comes with a guide wire for the insertion through the video laryngoscopy, and the red is used for monitoring the airway pressure and the end-tidal carbon dioxide. And you have a adjustable length indicator. It has an advantage to be used with monsoon jet ventilator, as the driving pressure can be set to achieve the desired tidal volume, and whenever you're using with the monsoon jet ventilator, the FiO2 automatically drops to 21% when the laser is being fired. So what should be my plan of anesthesia? It can be either controlled ventilation, intermittent apneic technique ventilation, jet ventilation, or spontaneous ventilation. There is no clear consensus about the ideal ventilation mode. Selection is done based on thorough understanding of the pathophysiology of the airway obstruction and the individual experience with the use of this device. In the post-op state, you keep the patient in semi-recoverant position, administer humidified oxygen, and closely observe for any signs of airway obstruction due to laryngeal edema or spasm, and manage the postoperative pain with analgesics, and always keep a difficult airway cart in the recovery until the patient fulfills the discharge criteria. Guidelines for safe anesthesia. The FiO2 should be kept as low as possible, less than 30%, and avoid nitrous oxide. If you're using a laser tube, the cuff should be filled with saline with the methylene blue for indication. Limit the laser use to short pulse and lower power. Cover the patient's face and the exposed part around the suspension laryngoscopy with wet towels, and the eye should be protected with wavelength specific eye protection. Encourage placement of saline soaked pages in the airway. The take home message: always work as a team and have a good communication and cooperation with the surgeon and the operating staff, as laser airway surgery is unique. Be familiar with the principles of laser, its advantage and hazards. Do a thorough preoperative evaluation and be prepared for the alteration in the plan. Understand the components of triad and take steps to prevent airway hazards. The choice of the anesthetic technique is dedicated by the experience of the anesthetic. Plan for a smooth extubation and give a good postoperative care. Thank you. These are my references. I had few questions. I think we'll take it up afterwards.
Okay. Thank you, Dr. Mamata, for that excellent presentation, because the topic is less discussed because we don't often use this laser as far as the airway surgery is concerned, because the lasers are used in ophthalmic procedures, dermatology, urology. We do see, but today's focus was mostly on the airway. So also was the topic what was presented by Dr. Shoba. That was the focused on the airway procedures only. So therefore, there are a few questions in the question box. Dr. Shoba, can you take those questions?
Sir, but
What are the
actually,
ventilation challenges?
sir, actually, the questions are not related to the
Yes.
today's topic. But even then, as a PG educative program, if anybody wishes to answer, they can answer, or else the moderator or myself has to take, because it is educative section. I cannot say that it is out of syllabus question, but it is the questions asked are out of syllabus only.
Yes, yes,
So
sure.
it is the moderator's decision. Moderator's decision to
No, it's all right. We will
allow
share.
the answers.
See, basically the thing is, these both the topics what we do are highly specialized ones, because they deal with only the airway. And second point is, these airway procedures are less commonly performed procedures, because we're all used to the endotracheal tube intubation. So the whether it's a laser procedure or the jet ventilations are not commonly used procedures. However, I ask Dr. Shoba to just look into the questions, and you just share your thoughts.
So what are the ventilation challenges in patients with bronchopleural fistula, and how are they being managed? So this is one of the indication which I said. Basically, it comes in the critical care as such. So as I said, because of conventional ventilation, it increases the air leak because of the higher tidal volume that's being set, usually at 5 to 8 ml, which will be. So by using the jet ventilation, so at a rate of 120, even up to 400, 500 breaths per minute, we can reduce the amount of the air leak that happens along with this sound. So main concern will be increasing the rate, and the PEEP can be reduced here, so that there is less amount of the leak which is happening, so which can manage the oxygenation within the lungs.
So that is the only question. The other questions were related to the how do you balance the
Sir, with the moderator's permission, as we don't know whether it is a postgraduate would have asked this question. So I prefer to answer, because questions to be answered. So the question, how do you balance the need for lung recruitment with the risk of ventilator-induced lung injury in a patient with refractory hypoxemia? See, even in jet ventilation, they have said, slowly you have to increase the support. So even if it is a HFNC or HFJV, you have to slowly increase the support. That is the reason why the ventilator adjustments are there. So we can see the lung expansion by monitoring the SpO2 or ABG. So that is how we can balance the acute lung injury due to ventilation as well as the improvement. And another one, they have asked what is the criteria for prone ventilation in ARDS. See, in a refractory hypoxemia, even after additional lung recruitment in the supine position, if the oxygenation is not improving or the PaO2 bar FiO2 ratio is less than that 200, which is a definition for ARDS, then we have to go for prone position. And even in prone positioning, within 30 minutes, there will be a change in the oxygenation indices. Then only we can continue. But to have the full effect, a minimum of 18 to 24 hours of prone positioning is necessary in ventilating ARDS patients. And they have asked, how do you assess its effectiveness? The effectiveness can be assessed by improvement in oxygenation. Same way, the ratio of PaO2 to FiO2 ratio, then by X-ray chest, then by improvement in lung mechanics. If possible, even patient can be shifted to CT, but it is very difficult in a critical care setting. And as the ABG is increasing with the decreased work of breathing, in addition, we need not concentrate only on respiratory mechanics. We can concentrate on BP and the pulse rate. The pulse rate will be coming down and the hemodynamic stability will be there. So these are all the parameters to assess the thing. And for this bronchopleural fistula, as we know, if you are ventilating both the lungs, definitely it is going to end up in pneumothorax. So necessarily this H frequency jet ventilation, high frequency jet ventilation will be useful because the principle in ventilating bronchopleural fistula will be low tidal volume, low PEEP, and increased rate. That is the principle. But whatever we do, immediate chest drainage catheters has to be placed so that we can easily ventilate. In sophisticated centers, we can go for a bronchial blocker or a double human endotracheal tube with the preferential ventilation to one side. But these are all the out of syllabus questions for today's session. But I want to say, as an academic coordinator this time, I was extremely happy because exactly this is the one we wanted to deliver to the audience. So I will have it as a gold standard. I will here afterwards, I will pass on this webinar to the future participant because see, their dedication is extreme. Their dedication is extreme. Everyone has taken the presentation very seriously, and the visual effect you have given is tremendous. That is an easy way of teaching, and we are cornering only the postgraduates and the young anesthesiologists and their perfection of the timing. Exactly 7:35 they finished. 7:30 they have to finish, but we have taken initially the 5 minutes more. Goes 7:35, it is over. So I don't know how many rehearsals they would have taken because the perfection with which they executed, even a postgraduate. So under the leadership of the extreme senior Dr.Harsoor, see, it is beyond expectation. Really phenomenal. See, even you cannot miss even a single slide. If you miss a single slide, then it will be and they have not even wasted a single line. Every line conveyed a meaning, and the fantastic effect is this visual effect because most of the people would not have seen, because when we were ventilating as a student jet ventilation, we were with the Sanders injector we were doing. But now it is extremely developed, and even high frequency oscillation is available in majority of the corporate hospitals. So you are living in a sophisticated era, and it is always better to have a visual effect, and you have done extremely well. So I congratulate the whole team, and I request Dr.Harsoor sir, our past president ISA National, to deliver his concluding remarks.
Thank you, Dr. Meenakshi. It was a wonderful experience with our young and energetic speakers, both representing our one of the prestigious institutes of Karnataka, Bangalore Medical College and Research Institute. And so also is the postgraduate. They have done a wonderful job. As you rightly identified, or I don't know whether they have told, they have done a very, very good rehearsal, keeping the type in front of them. And also I did tell them to use the artificial intelligence tools what are available to improve the quality of the slides and the visual effects. To that extent, they have done an very, very good job, I should say. And because I am conscious of what the presentations they're making, they did stick to the timing. they did create the slides as per their time and what the knowledge is. Of course, these questions were slightly out of box. So therefore, as an expert and a seasoned intensivist, you have answered them well. Hope to the satisfaction of the person who has asked that question. So thank you very much. Over to Mamata for the questions. How many questions you have?
Sir, only 3 questions, sir.
Okay, what are the things? Just you can read out the question and also give the answers to the audience present here.
During laser microsurgery of the larynx using endotracheal tube, a fire occurs in the airway. Which of the following is the most appropriate initial management? Increase the FiO2 to 1%, that is the 100%. Instill saline into the endotracheal tube. Perform cricothyrotomy. Remove endotracheal tube. Ventilate with air.
There is no answer pad, I think. Probably you can just give the answer and continue with the other question.
Actually, sir, this we have not expected. Now we have not given because the participants has to post the answers in the chat box and the platform people have to transfer the questions to Zoom. That is the reason I asked. Usually they will prepare it as a PowerPoint. I said it, then they post the questions. So it is the second level only we will get the questions. First they will get the questions. So I think madam can answer as eye opener.
And then you can.
And another one, probably you would have expected that there will not be any questions. You have come out with the questions and answers. But the thing is, see, majority of the people would not have seen that. And majority may be the first year postgraduates. And even the seasoned anesthesiologist would not have seen this unless or otherwise it is a specialized ENT surgical theater. It is very difficult. So you excuse them.
Okay.
You please answer the questions.
Okay. The most appropriate initial management is to remove the endotracheal tube. Next question. During surgery with carbon dioxide laser, which inhaled anesthetic gas mixture is the least likely to promote combustion of the endotracheal tube? Oxygen 25% with helium 75%, oxygen 25% with nitrogen 75%, oxygen 25% with nitrous 75%, nitrous oxide 75%, oxygen and nitrous in the ratio of 50:50, oxygen 50% and nitrous oxide 50%. So oxygen 25% with helium 75% is the least likely to promote combustion of the endotracheal tube. The third question is, reduction of fire hazards during laser surgery of the airway is best accomplished by the use of continuous mode of laser emission, nitrous oxide opioid relaxant anesthetic technique, PVC endotracheal tube with a cuff, topical lignocaine, saline filled sponges over the exposed tissue. Best accomplished is saline filled sponges over the exposed tissue. Jet ventilation technique uses an injector during the laryngobronchoscopy relies on air entrainment, relative density of the inhaled gases, presence of an endotracheal tube, presence of spontaneous ventilation, and use of helium oxygen mixture. The technique, jet ventilation technique, uses a jet injector during laryngoscopy relies on air entrainment.
I think Dr. Shoba also had some fill up the blanks.
Yes,
So
sir.
let
Can
her
I
fill
just?
up the blanks.
I'll just share it off, sir.
Dr. Priyanka is to become an examiner soon. She will also ask questions.
So one of the question was, the most effective way to increase the carbon dioxide elimination is by increasing the driving pressure, and the frequency can be kept unchanged. Because most of the hospital doesn't have a jet ventilator. So in absence of jet ventilator, what are the basic requirements for securing percutaneous translaryngeal jet ventilation is? The answer is, so we can use a 14 gauge or a 16 gauge IV catheter over the needle with a 3 syringe barrel with a 15 mm standard endotracheal tube connector, so which will be connected to the ventilating bag. So we can give a small breath till we buy some help. We can use this method.
This is only a rescue maneuver. This is only
Yes.
a rescue maneuver.
Rescue till we get the proper definitive way of managing the airways.
Thank you. Then I want to answer Dr. Harsoor sir's question. See, these people have never informed me that they have gone for a rehearsal. But see, as you said, see, we people are elderly, but you are physiologically young. We know which horse will win the race and which horse has got training. See, the precision with which they finished, without a rehearsal, it is not possible. It is a military precision. So it is my assumption only. And we need not tell them to use artificial intelligence because they are naturally intelligent to use artificial intelligence. So they are so good at that. They are having that NI to use that AI. And even you are talking about that carbon dioxide laser and the theater, even in my theater personal nursing home, I have this carbon dioxide extinguisher, fire extinguisher for the theater only. It is in between the two theaters, it will be placed. All the other areas, other extinguishers will be there. Usually for any theater fire, the better is carbon dioxide extinguisher, but you are talking about carbon dioxide laser. So if that moderator is ready to conclude, then thank you. Now I will request Dr. Hema, Treasurer, Puthukkottai ISA City Branch, to propose vote of thanks.
Good evening, everyone. I thank you all for your participation in the second edition of the third session from ISA Puthukkottai on today's topic on ventilation strategies, laser in an airway surgeries. I thank Dr. Meenakshi Sundaram, sir, our academic chairman, for guiding us in this academic event. I thank the moderator, Dr. Harsoor, sir, Professor, Department of Anesthesiology, Dr. Ambedkar Medical College, Bangalore. Thank you, sir. And I thank Dr. Priyanka, postgraduate Department of Anesthesia, on her presentation on HFNO in anesthesia and critical care with her wonderful videography demonstration. Thank you, Priyanka. I thank Dr. Shoba, Assistant Professor, Department of Anesthesiology, Bangalore Medical College, on jet ventilation in OR for her illustrations and videographic presentation with a detailed and elaborate presentation. Thank you, Madam Shoba. Thank you. I thank Dr. Mamata, Assistant Professor, Department of Anesthesiology, Bangalore, for anesthesia and laser airway surgeries. That was a very enlightening and extensive presentation. Thank you, Dr. Mamata. I thank Clarinet for your cooperation. And I thank all the attendees. Thank you all for your time and participation. I congratulate today's participation from Bangalore Medical College Anesthesia Department. Thank you. We look forward for your continuous participation in the future sessions. Thank you. Good evening.
Thank you. Next webinar, we will meet with the airway algorithms. I hand over the session to Clarinet.
Thank you so much, sir. Thank you so much, everyone, for giving us the opportunity to host this session. I would like to thank all the speaker doctors, chairperson, and I extend my gratitude